The next presentation is Findings from Widefield Color Photo for Diabetic Retinopathy Prognosis, presented by Dr. Lloyd Aiello.
Thank you very much. These are my disclosures. Two are pertinent. The Optos has provided travel support and equipment on loan, and although I've held numerous positions in the DRCR Retina network, for the purposes of this presentation, I am not speaking on behalf of the network. Now, we're all aware of the major advances in wide-field retinal imaging that occurred recently. And ever since we saw images of just how much additional retina we can now evaluate in detail, it's begged the question, does the additional retinal area visualized by ultra-wide-field color imaging benefit clinical care? And we're now beginning to think that indeed it may, in part because of work on predominantly peripheral lesions called PPL. PPL are defined when more DR lesions are located outside an ETDRS field than within the same field. Looking at the DRCR network protocol AA baseline data, this is an ongoing 4-year study evaluating 766 eyes, asking these sorts of questions. From the baseline data that was published in January, PPL were present in 41% of eyes, and these lesions suggested a 2 or more step increased DR severity in about 11%. And these findings were consistent with prior reports. The DRCR AA trial, of course, is ongoing, but there have been studies that have looked at retinopathy progression over 4 years in eyes with no or mild NPDR at baseline. Here's shown the original data in 109 eyes. And in eyes with PPL at baseline, shown in the yellow column, 2 or more step progression was over 3 times more likely, and PDR onset was over 4 times more likely than those eyes that did not have PPL at baseline. Now, an interesting finding from that study, shown on your left, and also from the protocol AA baseline data shown on your right, is that the vast majority of the lesions in PPL are actually hemorrhages and microaneurysms, 85 to 95%. This is interesting because we know, of course, that within the ETDRS field area, HMA counts are important in assessing disease activity. And is shown by over 1,000 images of HMA locations on the right. Many of these HMAs are located outside the ETDRS7 fields. Thus, given their frequency and wide distribution in the periphery, HMA counts on ultra-wide-field images might provide improved prediction of DR progression and PDR onset. HMA are also amenable to fully automated HMA detection algorithms. The one that's been used here were provided by Optos with AUCs of 90 to 95% versus masked manual counts. You can then automatically define a component called HMA-PPL, where 1 or more fields with a number of HMA in the periphery greater than in the corresponding ETDRS field. This can analyze large number of eyes, shown here data in over 1,300 eyes, with no DR or with any level of NPDR, where there were baseline and 4-year follow-up ultra-wide-field images. These were evaluated for 4-year DR progression, PDR onset, and need for intravitreal injection. Again, eyes with HMA-PPL at baseline in the yellow, and you can see that 2 or more step progression was increased over 2-fold, PDR onset over 4-fold, intravitreal injections about 2.5-fold, or the composite endpoint of all those, again, over 2.5-fold, more likely in eyes with PPL at baseline than when they were absent at baseline, defined now just by automated grading of these 1,300 eyes. Furthermore, progression risk increases with increasing extent of HMA-PPL at baseline. When there was no HMA-PPL present, the risk was about 6% for the composite endpoint, doubling to 12% with 1 field, increasing to 20% after 2 fields, and up to 33% for 3 or more fields with HMA-PPL. Now, the fact this can be automated means you can also put through very large numbers and start to look at things that would be difficult otherwise. This, for example, data that Dr. Silva presented at the ARVO meeting this year, in over 12,000 eyes with any non-proliferative DR severity and gradable ultra-wide-field images that were analyzed in this way and then compared to the electronic medical record. HMA-PPL was associated with a prevalence increase of 30% in patients with anemia, 38% for microalbuminuria, 22% for overt nephropathy, and 12% for chronic kidney disease. These studies suggest that PPL may also then be an indicator of systemic disease in diabetes. But in the eye, PPL evaluation identifies eyes at higher risk of progression within the same ETDRS DR severity level than is possible with standard imaging. This is particularly pertinent in telemedicine, where the peripheral retinal changes are not routinely evaluated. It's also gaining importance because there are recommendations for extended follow-up intervals that have been suggested based on imaging results to ease economic, provider, and patient burdens. Indeed, 3- and 4-year follow-up intervals for eyes with mild NPDR and no DR have been proposed, in some cases based on very excellent data, such as the DCCT and EDIC data set published in the New England Journal in 2017. However, we should keep in mind that none of these studies have produced these recommendations incorporating PPL evaluations in their guidelines. Now, if you're going to have a guideline for extended follow-up, you would generally like the event rate during that period to be very low, generally a guideline of 5% or less. Here, looking at eyes with only mild NPDR at baseline, again, over 4 years. In eyes without PPL, the event rate was very low, 1.6% for 2 or more step regression, 1% for PDR onset or the need for PRP. However, in these eyes of this cohort, the 12% that had PPL at baseline, these went up to 9%, well above the general criteria of 5%. So while we await the findings of DRCR Protocol AA, which is specifically addressing PPL outcomes over 4 years, current findings suggest that follow-up duration should not be extended for patients with no mild or moderate non-proliferative diabetic retinopathy without first evaluating the retinal periphery. So overall, the retinal periphery appears to hold substantial information that may permit better assessment of retinopathy progression risk. Evolving technologies such as AI, peripheral OCT, ultra-widefield FA, and others may yield additional predictive value if they are used to assess the retinal periphery, and several of these are already looking at such parameters. If such findings are confirmed, current standard diabetic retinopathy severity grading approaches may require modification to include these parameters for optimal retinopathy risk assessment. Thank you.